Good morning. Good morning and welcome to the 122nd Landon Lecture on Public Affairs. The Landon Lectures were begun in 1966 by the late Governor, Alf Landon, and the late K-State President, James McCain. The goal of the Landon Lectures is to bring the most prominent public figures to Kansas State University to discuss the pressing issues of the day. We are very pleased today to welcome Dr. David Satcher to the Landon podium to join 121 predecessors in bringing their thoughts and opinions on important public issues. Before introducing Dr. Satcher, I would like to introduce other members of the platform party. On my left, Dr. Sia Sheldon, Professor of Sociology, Anthropology, and Social Work, and President of the Kansas State University Faculty Senate. Sia? Next to her, Kyle Barker, a senior in political science and journalism and student body president. On my right, the chairman of the Landon Patrons, Edward Seaton, editor-in-chief and publisher of the Manhattan Mercury. Ed, thank you. And next to him, Dr. Charles Reagan, associate to the president and chairman of the Landon Lecture Series. Dr. David Satcher is the 16th Surgeon General of the United States, and his term runs through February of 2002. When he was sworn in on February 13, 1998, he became only the second person in history to have held positions of Surgeon General and Assistant Secretary for Health at the same time. Before being appointed by President Clinton to his current position, Dr. Satcher served as the director of the Centers for Disease Control and Prevention and the administrator of the Agency for Toxic Substances and Disease Registry. Before his government service, he was president of the Meharry Medical College in Nashville, Tennessee. He has been a professor and chairman of the Department of Community Medicine and Family Practice at the Morehouse School of Medicine. He has served on the faculty of the UCLA School of Medicine and Public Health. Early in his career, he served as the interim dean of the Charles R. Drew Postgraduate Medical School. Surgeon General and Assistant Secretary for Health, Dr. Satcher has led his department's efforts to eliminate racial and ethnic disparities in health. He also released the Surgeon General's reports on tobacco and health, women and smoking, mental health. That was followed by a supplement on children's mental health and reports on suicide prevention, oral health, and youth violence prevention. Among his many honors, he has been a Robert Wood Johnson Clinical Scholar and a Macy Faculty Fellow. He has received more than 24 honorary degrees and top awards from the National Medical Association, the AMA, the American College of Physicians, the American Academy of Family Physicians, and the American Academy for the Advancement of Science. Dr. Satcher graduated from Morehouse College in Atlanta, is a member of Phi Beta Kappa. He received his MD and PhD degrees from Case Western Reserve University. And certainly we appreciate so much that he was able to make it to Manhattan, Kansas, and Kansas State. So please help me welcome the Chief Medical Officer of the United States, Surgeon General, Dr. David Satcher. Thank you so much.
Thank you very much, President Weefall, for that very kind introduction to the Landon patrons, other university officials, members of the faculty and students, community, and to all of you distinguished people. I'm delighted to be here, bringing greetings from Washington, D.C. It's not easy to get from there to here, especially this time of the year with all of the things that are going on, but we had a very safe trip yesterday. I'm delighted to be here today and certainly to be a part of this outstanding Landon Lecture Series. Certainly Governor Landon was truly a remarkable person and a legendary leader, and I consider it a distinct honor to deliver the lecture that bears his name. And certainly following his impressive leadership, of course, his daughter, Nancy Kassenbaum Baker, did an outstanding job as senator. She has certainly been one of my favorite people because of the spirit of civility and bipartisan productivity that she brought to the Senate, something that was so greatly needed and is still greatly needed today. So I'm delighted to be here. These are difficult times, and all of our hearts go out to those who lost their lives or was injured in a terrorist attack that took place last Tuesday. I was on my way to the Union Station. I was to lecture at Princeton Tuesday afternoon and then catch a plane to South America to help Uruguay launch their Healthy People 2010 when the news came of the attacks at the World Trade Center. And as Surgeon General, I immediately activated the Commissioned Corps Readiness Force. Now, most people understand the role of the Surgeon General when it comes to the responsibility to communicate directly with the American people on issues related to their health and the health of family and community. Probably less well understood is the role of the Surgeon General as the commander of the Commissioned Corps of the Public Health Service. But we have about 5,600 members of the Commissioned Corps. For the most part, they're health professionals. We also have engineers in the Commissioned Corps. Veterinarians play a tremendous role in the Commissioned Corps in a lot of our investigations. But the Commissioned Corps group of people are on call 24 hours a day, 7 days a week to respond to any threat or emergency impacting the health of the American people. So we called them to active duty 1 week ago, and they have played a tremendous role in rescue operations in New York City, at the Pentagon, and in Pennsylvania, including members of the DMART team who are now making a major effort to identify bodies. But the thing that's really impressed me so is that there are about 800 members of the Commissioned Corps Readiness Force, people who are highly trained and highly skilled, and we put them on notice that many of them would be called up. And we've had a lot of people calling in the last few days complaining that they were not called yet. It's amazing the spirit with which people are responding to this disaster. So it reminds me of a story which Andrew Attaway shared in the Guidepost Daily Guide Word a few years ago. It was about his daughter, Elizabeth. At the time, she was 2.5 years old. And Andrew Attaway wrote about his daughter and how her favorite thing was to have her dad read to her. Her favorite book was a book given to her by her grandmother. And in that book, her favorite story was The Good Samaritan. And Andrew Attaway has read this story to his daughter many times. And so he decided to quiz her. And so he asked her about the story. You know the story. The man was on his way from Jerusalem to Jericho and fell among thieves, was robbed and beaten severely, left bleeding to die. And of course, along came a priest who was on his way to church and looked over at the man and decided that he was running late, and so he couldn't stop to help him. And then another man passed by, a Levite. He was not late, but he asked a question that many of us ask. He said, "This is a very dangerous curve, and what will happen to me if I stop to help this man?" And so he went on. And then a man came by whom nobody expected to stop, a Samaritan. He was on his horse, looked over, and he asked a different question. What will happen to this man if I don't stop to help him? So he got on off his horse and stopped the bleeding, bound up the wounds, took the man into town and left him for care and said, "I'll pay you whatever it costs." So Andrew Attaway read the story to his daughter Elizabeth, and then he quizzes her. Where was the man going? She remembered he was on his way from Jerusalem to Jericho. He asked what happened to the man, and she described that he was beaten and he was bleeding. And then he says, Elizabeth, did the priest stop? And Elizabeth said, yes, the priest stopped to help. So Andrew Attaway reads the story again to Elizabeth. And he asked the same question, did the priest stop? And she said, yes. And after a while, he gets really frustrated. He says, now, Elizabeth, I've read this story to you many, many times. And every time I ask you if the priest stopped, and you say yes. And Elizabeth said, but Daddy, I want the priest to stop. I want the story to be different. Well, I don't know about you, but I sort of feel that way about last Tuesday. Sometimes I keep hoping that I'm going to wake up and find out that it didn't really happen, that it was just a dream. But I think we're not children. We know that we can't change the past. But I think together we can certainly shape the future. And I want to talk about one aspect of that future, and that is the health of the American people and our role in terms of the global health. Since 1979, we have been involved in a process in this country called Healthy People. In fact, it was Julie Richmond, Dr. Julius Richmond, the only other person who served as both Surgeon General and Assistant Secretary for Health, who released the Surgeon General's report in 1979 called Health Promotion and Disease Prevention. And in that report, he recommended that the nation embark upon a process of planning for the health of the American people on a 10-year basis. That we would set goals and objectives, measurable objectives. And the first Healthy People program was released in 1980, and it was called Healthy People 90, because that was the date at which it would end and be evaluated. And then in 1990, we released Healthy People 2000. When I came on as Surgeon General, we were coming to the end of Healthy People 2000, and we looked very critically at what we had done. We traveled all over the country to get input as to what should be the major thrust of Healthy People 2010. And in January of 2000, Donna Shalala, who was then Secretary, and I released Healthy People 2010. There are two goals for Healthy People 2010. One goal is sort of a response to the fact that we as a nation are aging. There are now in this country over 35 million people over 65 years of age. And we're estimating that by 2030 there could be 70 million people over 65 years of age. In fact, the fastest growing group of people in America today are people over 85. So we have made a lot of progress in improving the years of life that people live. So the first goal of Healthy People 2010 is to work to improve the quality as well as the years of healthy life. And it focuses on areas such as chronic pain and depression, Alzheimer's, Parkinson's, lower back pain, and all of those areas where we see a lot of problems in terms of the elderly. But it's not just concerned about quality of life from the perspective of the elderly. We believe that quality of life begins at birth or at conception. For example, whether or not a baby's breastfed has a lot to do with the quality of life. Certainly, whether or not a child receives immunizations on time. A child who is abused early in life suffers an impact on quality of life for the rest of his or her life. A child who suffers from asthma and who cannot predict when the next asthma attack is going to come on suffers a diminished quality of life. So the quality of life goal is one that involves a lot of objectives relating to, on the one hand, improving the independence of older Americans and dealing with problems that older Americans face, but also looking at every step in life as to how we can improve the quality of life throughout life. The second goal of Healthy People 2010 is a goal which acknowledges that we as a nation are becoming more diverse. In fact, diversity is one of the striking characteristics of our country and should be one of our major strengths as a nation. In the area of health, we have been concerned about disparities in health among different racial and ethnic groups in this country. So one of the goals of Healthy People 2010 is to work toward the elimination of disparities in health. We began by focusing on 6 major areas of disparities: infant mortality, cardiovascular disease, including stroke, cancer, and especially cancer morbidity and mortality, diabetes, which is a really interesting area because it's one of the areas where we've seen a dramatic increase in the last 10 years in this country, the HIV/AIDS epidemic, and finally, immunizations, childhood immunizations, where we've made so much progress in the last 10 years, but also adult immunizations, the influenza vaccine, the pneumococcal vaccines, that could really save so many lives in this country if we could get more adults over 65 immunized. But there are disparities in each of these areas. For example, today in this country, an African-American baby born is 2.5 times as likely to die in the first year of life as a majority baby. An American Indian baby is about twice as likely to die in the first year of life. In the area of cardiovascular diseases, there are major disparities among different racial and ethnic groups, including the Asian Pacific Islanders at increased risk, African-American males especially, and females at increased risk of heart disease and stroke. In the area of cancer, there are dramatic disparities. White women in this country have the greatest risk for breast cancer of any group. African-American women have the greatest mortality rate. Now, we have made significant progress in the last 10 years, and really for the first time in the last 10 years, at reducing cancer mortality, especially cancer of the breast, where the reduction has been more than 20%. We've got to keep that going, and I think we will, as well as some other areas of cancer mortality. But there are disparities. Asian Americans suffer disproportionately cancer of the liver, and most of that is related to hepatitis, and many Asian Americans who come to this country have experienced hepatitis. Of course, a lot of Americans suffer hepatitis, but it's disproportionately seen in Asian Americans, and so that goes on in many cases to cancer of the liver, so there's a disproportionate impact. I think diabetes is one of the most interesting problems we're facing in this country today for many reasons. For one thing, of course, we've seen a dramatic increase in the number of Americans who suffer diabetes. I think it was about 4.5% about 20 years ago, and we're now up to around 7% of Americans experiencing type 2 diabetes, that type that's related to overweight and obesity especially. There are disparities. Native Americans or American Indians are at the greatest risk for type 2 diabetes, and they suffer it at least 3 to 5 times the risk as the majority population. And it's interesting because while we see that in this country, if you look at the same populations, or certainly relatives of them in parts of Mexico, we don't see the same rates of type 2 diabetes. Hispanics in this country are at least twice as likely to suffer type 2 diabetes. And diabetes, of course, often goes on to cause complications such as blindness and the need for lower limb amputation and end-stage renal disease. So there are a lot of people throughout the country on renal dialysis. As I visit reservations, for example, even in some of our smallest hospitals, and you see many people on dialysis for end-stage renal disease. African Americans have an unusually high mortality rate from diabetes because it often comes together with hypertension, and they both, of course, work on the kidneys and cause end-stage renal disease as well as other cardiovascular diseases. But again, one of the most striking things about diabetes, of course, and we're learning more every day, is the tremendous ability that we have to prevent type 2 diabetes through programs of health promotion and disease prevention, which I'll mention later. But it's one of those areas where attacking lifestyle, if you will, is critical. There are disparities in the AIDS epidemic, an epidemic which started as primarily an epidemic of white gay men in this country, has evolved over the years to affect disproportionately minorities and the poor. And so all of the recent reports to the CDC show a disproportionate impact on Hispanics and African Americans in terms of HIV/AIDS. Those are just examples of disparities that we're facing in health. Now, in Healthy People 2010, we have a lot of objectives. In fact, we have over 400. And one of my concerns, of course, was how do you communicate 400 plus objectives to the American people? You can't do it. Now, I want to assure you that there's somebody who's interested in every one of those objectives. There's some group that really focuses on area objectives. For example, for the first time in Healthy People 2010, we have areas dealing with hearing and visual disorders. We didn't have that before. We have health communication for the first time. And in all of these areas, there are agencies within government and there are community organizations that are focusing. The American Heart Association, for example, focuses on objectives dealing with cardiovascular disease and stroke. The American Cancer Society, they joined the National Cancer Institute. So all of these objectives have a lot of people and resources behind them. But the question is, how do you, as Surgeon General, communicate Healthy People 2010 to the American people when you're dealing with 467 objectives? We decided that it couldn't be done. So what we decided to do, working with the Institute of Medicine, was to try to identify a small set of leading health indicators that would capture the essence of Healthy People 2010 and that we could communicate to the American people. So we worked with the Institute of Medicine. We used regression analysis to try to conceptualize the major areas. And we ended up with 10 leading health indicators that we felt captured the essence of Healthy People 2010. And I want to leave those with you. Of those 10 leading health indicators, 5 of them relate to the health system, beginning with access to care, because there are major disparities in access. We still have over 40 million American people who are uninsured. Hispanics, of course, are most likely to be uninsured, more than 1 out of 3 Hispanics. But it goes beyond that. If you ask Hispanics if they have a personal physician, then as high as 46 to 50% report that they do not. 1 in 4 African Americans in this country are uninsured. But if you ask them about whether they have a physician, almost 40% report that they do not. So it becomes a problem at the outset in terms of, are people really getting comprehensive health care, especially primary care, where problems are discovered early, where providers have the opportunity to communicate about things you can do to improve your health. And so we decided that access to care, especially for prenatal care, should be one of our major targets for Healthy People 2010. In the area of the health systems, another major area that I've dealt with, and many of you are interested in, of course, from your work, is mental health. In December of 1999, I released the first ever Surgeon General's report on mental health. And in that report, we said, among other things, that mental health is fundamental to overall health and well-being. That mental disorders are real in the sense that they are, in fact, physical disorders. They have bases in the brain. We've studied the brain now intensely, and over the last 25 to 30 years, it's very clear that most mental disorders can be traced to changes in the neurons of the brain, or the secretions, the connections. And so mental disorders are real. And not only that, mental disorders are treatable. 80 to 90% of the time today, we can treat people with mental illness and return them to productive lives and positive relationships. And that was the good news in that Surgeon General's report. We can treat people. We can return them to productive lives, positive relationships. The bad news in that report was that of the 1 in 5 Americans who suffer a mental disorder each year, about 20%, 44 million people, of that number, less than half even seek treatment. And you say, well, why is that? Because of the stigma that still surrounds mental illness in this country. And I should say stigma and discrimination, because there's still people who won't hire people who have a history of mental illness. There's still people who don't promote people who have a history of mental illness. So we have a problem, and not just we, America, it's a major global problem, in that this very real health problem, which is diagnosable and treatable, is still surrounded by an aura of stigma and discrimination. So people are not comfortable. People who have children with mental disorders often hesitate to take them for care. They don't want other people to know. And so what it does is it adds to the problem, and we end up seeing the products of our mental health problems in the homeless populations on our streets in many cases, and also in many cases in our jails and prisons. So our strategy here is to really try to remove the stigma surrounding mental illness and to improve the health system so that there's parity of access for mental health problems. And I think we're making some progress. Several states have changed their laws, and several states have now removed barriers to access. Now, the suicide reports that we did, I think, I'll just say one thing about those reports, and we released the National Strategy for Suicide Prevention last year, in fact, this year in the spring. What we found was that, of course, suicides are very common. There are 3 people who take their own lives in this country every year for every 2 people who die by homicide. And 80 to 90% of the time, perhaps as high as 95% in some people's estimation, people who commit suicide are suffering from some mental disorder, usually depression, but certainly people who are schizophrenic are at increased risk for suicide, and certainly bipolar disease, even certain personality disorders. So again, we believe that many suicides are preventable in the sense that if mental health problems are diagnosed early and we intervene, we believe that we can reduce suicides. Now, I'm not even able to get into the issue of suicides when they are combined with homicides, like we've seen the Columbine shooting, for example, where the 2 students not only took the lives of 12 others, but took their own. And I can't begin to get into the mentality that would lead people to do the kind of things that the 19 people who were flying those planes the other day. But so we have some interesting dynamics going on here that are, as it relates to mental health, but even some issues beyond mental health. That's mental health, and it was a major part of Healthy People 2010. Immunizations are a major part. The prevention of injury and violence, another major part of Healthy People 2010. And environment, major concerns about environmental hazards. But let me close by mentioning the 5 leading health indicators that relate to lifestyle. And I want you to think about this. These are lifestyle, these are human behavior. We estimate that human behavior can account for over half of the deaths that we suffer in this country every year. And in Healthy People 2010, we've included physical activity, overweight and obesity. We've included substance abuse, tobacco use, and responsible sexual behavior. And it's interesting, we were talking last night about the Surgeon General's prescription. Now, this is the Surgeon General's prescription. Now, that's not the actual size. It's, the size of a doctor's prescription. But when they told me that I was the nation's doctor, I said, well, I've been writing prescriptions all of my life as a physician, so maybe as Surgeon General, I ought to write a prescription for the American people. So 2 years ago, we released the Surgeon General's prescription, and we've distributed them all over the country and the world, really. I want to share with you what's on this prescription. And you think about your own life and habits. The first thing on the Surgeon General's prescription is physical activity, moderate physical activity, things like walking, jogging, biking, swimming, gardening, things that anybody can do. We recommend at least 30 minutes a day, 5 days a week. There are not many Americans who meet that requirement yet, by the way. The second thing on this prescription is good nutrition. And the focus here is on the 5-a-day program that we've been pushing. That is, we recommend that Americans consume at least 5 servings of fruits and vegetables per day. And again, only about 10% or less of Americans meet that requirement. The third thing on this prescription is to avoid toxins, especially tobacco, that's responsible for over 430,000 deaths in this country every year. Tobacco is still the leading cause of death among behaviorals. And when I released the Surgeon General's report on women and smoking earlier this year, a lot of people were shocked to learn that more women die from lung cancer every year in this country than breast cancer. In fact, last year, 27,000 more women in America died from lung cancer than breast cancer. And it's not because there's been a decrease in smoking in this country since 1964, when the first Surgeon General's report was released. But women started to smoke after 1950, and that increased for several years. And now we're seeing the products of that in increased deaths from lung cancer and other cancers as well. But we also advise the avoiding of toxins like illicit drugs, heroin, cocaine, but also alcohol. The abuse of alcohol is one of our major health problems. In fact, 100,000 people in this country die every year from alcohol. And it has been an increasing problem among teenagers and on our college campuses, binge drinking. Binge drinking interferes with, obviously, the academics on college campus, but also increases violence and motor vehicle deaths. So we believe that we should have a frontal attack on alcohol abuse. A child that begins to drink before the age of 15 is 4 times as likely to become alcoholic as someone who begins to drink after 21 years of age. So parents have a very important responsibility here. The last item on the Surgeon General's prescription is sexual health, responsible sexual behavior. We still have a lot of trouble in this country talking about sex. Some people said that we talk about it in all the wrong places, in all the wrong ways, but not in the right places. And so under responsible sexual behavior, we start off by saying abstinence where appropriate, and we have been trying to especially make it clear to young people that relationships should not begin with sex. They should begin with communication and understanding and respect and appreciation, and sex ought to be preserved for those very special, committed relationships, mutually monogamous relationships like marriage. And getting that message over to young people is so critical because there are so many other messages out there. Now, obviously, where I get in trouble as Surgeon General with some people is that I don't stop there. I say that for whatever reason, there are a lot of people out there who are sexually active, including 65 to 70% of our young people. And so our position is that anybody who's sexually active, regardless of age, ought to know what their responsibility is to themselves and others to prevent unintended pregnancies and to prevent the spread of sexually transmitted diseases, including HIV/AIDS. So we talk about protective sex, and we talk about the limitations of that, but also the fact that most cases of HIV/AIDS could be prevented from spread by the appropriate use of contraceptives. But we also try to make it very clear that sex is a very special thing that's not to be played with. Well, this is the Surgeon General's prescription. I've had some interesting experiences with it. I was in the airport in New Jersey. I had been to Princeton to speak to the Robert Wood Johnson Foundation's Board of Trustees one night, and I was anxious to get home. So I was in the Trenton train station waiting for the train, and a young man walked up to me and he said, "Man, you look just like the Surgeon General." I said, "Well, you know, there's a reason for that." And then he started screaming, "The Surgeon General is here, the Surgeon General is here." And people came running from all over the place. And the first guy who got there looked at him and said, "Man, you mean you're smoking in front of the Surgeon General?" So he threw his cigarette down and he stumped it, and I wrote him a prescription, stop smoking. Well, his buddy got a kick out of that. He was laughing. He said, "Well, what are you laughing about? I mean, you've gained 20 pounds in the last year." So I wrote him a prescription. Another guy, they said, "Well, you know, the way you play around, you're going to get AIDS." So I wrote, by the time the train came that night, I had written about 20 prescriptions. So I don't hesitate to write prescriptions. But seriously, the awesome responsibility which we have to take care of ourselves and our family is a major important part of being good citizens. I'm very concerned that overweight and obesity have increased in this country so dramatically in the last 20 years, including a doubling of overweight and obesity in our children and a tripling in overweight and obesity among adolescents just in the last 20 years. So if you look at adults in this country, over 50% of adults are now overweight and over 20% obese. And we have a cutoff for obese, so if you're 30% above the recommended, it's really, I won't explain, but it has to do with body mass index. And a body mass index of 25 is the upper limit of normal, so anything above that is overweight, between 25 and 30. And then after you get over 30 for body mass index, that becomes obesity. There are a lot of overweight and obese people in the country. So we do need to pay a lot of attention to our physical fitness and nutrition, and avoiding toxins. Because part of being a great nation, of course, is to be fit and to be ready to play our part, whatever that part happens to be, but also to make sure that for our children, that we do our best to get them started on healthy habits. Too many schools have discontinued the requirement of physical education K through 12. Many of those same schools sell pops in the vending machines and sweets. And so children are watching a lot of TV, eating snacks, less physically active than they've ever been. So the outcome, of course, is more avoiding obesity. Well, there's a story about a man who was flying across the country in a hot air balloon. At a certain point, he realized that he was lost, so he decided to lower the balloon to see if he could spot any recognizable landmarks. Got down to a certain level and didn't see anything he recognized, but kept going down. At about 30 feet, he spotted a man working in the field below. He yelled out, "Where am I?" And the man looked up at him and said, "Well, you're in a hot air balloon about 30 feet above ground." The guy in the hot air balloon said, "You sound like a scientist." And the man on the ground said, "I am a scientist. How in the world did you know?" And he said, "Because what you've told me is technically correct, but it is of absolutely no use to me right now." Well, the man on the ground said, "You sound like a policymaker." And the man in the hot air balloon said, I am a policymaker. How in the world did you know?" And he said, "Because you know you're in the same position you were when we met. You don't know where you are. You don't know where you're going. And now you're blaming me." I think one of the major challenges that we face in this country is to try to bring to bear the best science on our policies and practices. And it's serious business, and I know this university has contributed so much to food safety and security. And we have major challenges ahead in terms of bioterrorism, biological and chemical. And I know you're going to play a great role in that. We have to continue to do the science. But we have to also make sure that the science impacts upon how we do business in terms of our policies and practices. And we must continue to set high goals. These words of Benjamin Elijah Mays, who was president of Morehouse College when I was a student there, have stayed with me, and I'll leave them with you. It must be borne in mind that the great tragedy of life is not in failing to reach all your goals. It is in having no goals for which you're reaching. It's not a calamity to die with dreams unfulfilled, but it is a calamity not to dream. It's not a disaster if you fail to achieve your highest idea, but it is a disaster if you have no high ideas for which you're striving. It's not a disgrace to fail to reach the stars, but it is a disgrace to have no stars to reach. Not failure, but low aim is sin. Thank you.
Thank you very much. Thanks. Thank you very much. Would you like to answer some questions? Thank you very much, Dr. Satcher, for a very excellent Landon Lecture presentation here this morning. He has agreed to answer some of your questions, and so if you do have questions, we have mics on your left and on your right, so if you would just migrate there. Certainly.
The question was that, she said she was informed the other day that Medicaid services to children in Kansas for mental health services were going to be greatly reduced and limited to mental health institutions, centers. And the question is, what's the federal government doing? Well, there are several things happening on the federal and state level, but let me focus on the federal level. There is major legislation pending now in the House and the Senate that would require parity of access to mental health services. I think Senator Domenici and Wellstone introduced the legislation in the Senate. I forget who introduced it in the House, but there are at least 4 bills that relate to this whole issue of how can we break down the barriers to access to mental health services and to make sure that whether we're dealing with private insurance or public insurance like Medicaid and Medicare, that we eliminate the lack of parity in access. I think that legislation is very important because currently our federal programs actually discriminate in the sense that Medicare, for example, requires a 20% co-payment for outpatient services in general. But today, Medicare requires 50% co-payment for mental health services. So we have a problem in terms of governmental rules and regulations. Congress is working very hard to change that, and I think that will happen. Go right ahead. Who's next? Yes.
Let's try this one over here on the left.
Hi, much has been said recently about embryonic stem cell research, and I'd like to know your thoughts on the potential for this research to cure and prevent disease, and also what steps you think the government needs to take to regulate both private and publicly funded research.
It's a very good question. It's a tough one. First, I think there's tremendous potential in stem cell research, and make no mistake about it, there's a lot of research left to be done. And that's what we can't afford to forget, is that there's a lot of potential, but we've got to do the research. We've got to provide the opportunities for scientists to do the research. And as you know, President Bush recently took the position that federal funding would be available for the existing stem lines. And he predicted that there were about 60, there's been a lot of debate about whether there really are 60 usable. The position of NIH is still that there are at least 60 stem cell lines that could be used and federally funded. Now that cuts off the use of new embryonic cells, and it doesn't stop the private sector, and the government has made no indication of limiting private sector research in this area, but just said that federal funds will not be used beyond the existing stem cell lines. And that debate will continue, but I think the important thing is that the research will in fact continue. And we will learn, of course, how limited or how limiting the present regulations are over the next few years. I think the potential is great for areas like diabetes, for example, Alzheimer's, Parkinson's, even spinal cord injuries. I think the potential, as has been demonstrated in some low animals, the potential for stem cell research to make a tremendous difference in these areas is I think, real.
Okay, we'll try with this one over here.
I'd like to thank you for coming today, and I'd ask that you maybe say a few more words about your call to action to promote responsible sexual behavior and perhaps some action steps that the federal government and state governments can take to help implement some of the items that you laid out in that report.
Yeah, this was this was only the second call to action ever issued by a Surgeon General. The first one was a call to action for suicide prevention. The call to action to promote sexual health and responsible sexual behavior that includes several major recommendations. First, it said that parents should be the primary sex educators, and therefore it encourages parents to really talk with their children about sex, especially answer their questions, because as children develop, they have some very important questions about sexual development and differences, and it's important for parents to feel comfortable encouraging those questions, but also responding to them. And as the age-appropriate levels, adding more information. But we also went beyond that. We said that not all parents are equal in their ability or comfort, intellectual ability or emotional, to talk with their children about sex. So it's really critical that schools be involved in sex education. So we recommended that in fact it be, just like other aspects of health, that sexual health be a part of the curriculum of schools. And again, that it be based on the readiness of children at different age levels and their understanding of biology and chemistry to understand sex. But that behind it all is this message of responsibility that goes with sexual behavior. But beyond sexual behavior is just the whole issue of sexual health. everybody is sexual, regardless of whether they're sexually active. We are all sexual beings. Understanding and appreciating human sexuality and what that means and the role that it plays in our lives is so critical. So that's why we recommended that that take place. We even recommended that churches be involved in sex education. And I know that many ministers have written me saying that they were really pleased to see that and that they have in fact started programs in their church dealing with sex education. I mentioned what we said about the importance of responsible sexual behavior when one is sexually active. And I guess the most critical thing there was that some people said, Dr. Satcher, why did you say committed, enduring, mutually monogamous relationships? Why didn't you just say marriage? And I said, because not all marriages are mutually monogamous relationships. So I'm the Surgeon General. I mean, somebody else might want to say that, but my job is to talk about how do you keep people safe. And there are too many people who've gotten infected with AIDS in the context of their marriage, especially women who've been infected by their spouses. So whether that spouse was injecting drugs or sexually active outside of marriage or what have you, I don't know. But the fact of the matter is, the focus here is on mutually monogamous relationships. One of the other things that we said was so controversial and perhaps is responsible for the demonstrations outside is we talked about the science related to sexual orientation and said that that there is no, all of the evidence would suggest that sexual orientation is determined by adolescence. And we still have a lot more research to do, but to date, it would suggest that. And to date, despite all of the programs, very controversial, there's no evidence that sexual orientation can be changed. Now, some people said, well, you're wrong. I can tell you I know this person, that person. We're not talking about sexual behavior here. We're talking about sexual orientation. And the science does not show to date that it can be changed. So we said how critical it was for Americans to appreciate sexual diversity, and especially to stop the discrimination and the attacks that are so common in the country today around sexual orientation. That is, it's turned out to be a very controversial point, but we stand behind that. The science stands behind that. Okay. There's much more I could say, but I don't want to give the whole morning.
Yeah. Sir, I work for facilities right here at K-State. We're having a heated debate right now about asbestos. And I'm wondering how safe, it's everywhere, so how safe are we and how is it long-term on your lungs?
Well, some things that we certainly know about asbestos. We know that asbestos can cause lung disease, can cause serious lung disease. Maybe we don't know as much as we should about how much exposure over time. And we still have questions about the risk benefits. For example, many people argue that if the Twin Towers had used asbestos all the way up beyond the 40th floor, that more people would have survived because, as you know, asbestos is sort of fire resistant. And therefore, the argument is that we stopped using asbestos because of the health risk. And yet, because we didn't use asbestos, perhaps people died who wouldn't have because it was able to stop fire. Those kind of risk-benefit questions are very difficult. The fact of the matter is we know the dangers of asbestos, and therefore we almost have a responsibility to respond by recommending that people not be exposed to asbestos. Now, obviously, you worry about the exposure, so asbestos can probably be used in such a way that people are not exposed to it unless something happens like the other day. So there are many questions about asbestos. The research has to continue in terms of understanding, especially the risk-benefit ratio, if you will.
Thank you.
Okay, we have another question over here.
Yes. Hi, my name is Tammy Osborne, and I'm with the Student Health Advisory Committee, which is kind of like a liaison between the health center here at the university and the students. Mm-hmm. And one of the things that we're focusing on this year is international students and the differences in healthcare that they receive and what they need. And you kind of touched a little bit on the diverse issues in your talk. Mm-hmm. And one thing I was going to ask you is if you have any advice on a direction that we could look into or any other things that have come up in your line of work that are things you see at a university level we could look into and start implementing?
Well, it's a very important question. And the first point that I think needs to be made is that today, public health ought to be global health. In other words, we live in a global community, if you will. I know that may be overused, but at least 2 million people cross national borders every day. A person can have Ebola, get infected with Ebola today and be, 24 hours, if you will, from this country, regardless of almost from anywhere in the world, be in New York City or Manhattan, Kansas, within 24 hours or so. We live in a global community, and and it's not just infectious diseases, but we certainly know when we study emerging infectious diseases that these diseases can spread rapidly from one country to the other. So the reason we sent teams over to Zaire, Africa, when they had the Ebola outbreak, the last one I guess was 95, 96, is on the one hand, we live in a global community, so you want to stop an infection like Ebola in its tracks as soon as it could. Think what would have happened if the first cases of HIV/AIDS had been identified early and that we had been able to surround them and stop them so that they didn't spread further. If we had known that much about HIV, think about all the lives. There are now, 36 million people living with HIV. There have been 22 million deaths in the world. If we had identified that outbreak early, so global health, that means that wherever the infection is, we want to identify it as early as possible and bring global resources to bear. Beyond infectious diseases, tobacco is a global health problem. Environmental health is a global issue. So there are major disparities in health that exist throughout the world in the amount of money that's spent for health care. For example, in sub-Saharan Africa, if you have AIDS, it's very unlikely that you're going to be able to afford antiretroviral agents, even when they reduce the cost. I mean, in this country, people pay, or the government pays, $10,000 to $15,000 a year for treatment with antiretroviral agents. And the per capita income in most of Africa is less than $1,000 a year, much less. So you just think about the great gap, the disparity that exists in terms of being able to get the products of this science to people wherever they are. And yet it's a global problem. Unless we can stop this disease, and that's why we need a vaccine so desperately. We need to stop this disease, stop its spread, and therefore we've got to attack it wherever it is. So I think students ought to think about that, learn as much as they can about global health and the challenges of global health. The cooperation that's taking place is, for example, now in developing a vaccine. Thailand, Uganda, the United States, all working together to try to develop a vaccine to stop the spread of HIV.
Okay, I think we have time for one more question.
Good morning. My name is Melissa Green, and I'm currently a research scientist here on campus. And as you mentioned this morning, especially with people of color, there's a stigma attached to going to the doctor and getting the proper health care that is necessary. As a person who talks to many different older people of color who are still very afraid to see a physician, and then also as a person who has seen an increase in the number of physicians of color, what else can we do to dismay this stigma, so that people can get involved with going into clinical trials and getting involved in research studies, so that the numbers, when it comes to the proportions of health disease, when it comes to people of color, can start to decrease?
Very, very good question. It's a tough question. Back in, I guess it was 95, when I was director of CDC, when we had the apology by the president for the Tuskegee study. The reason we worked so hard to get that apology, we did a lot of background research on the Tuskegee study and the role the government played in it, where 400 black men in Tuskegee were observed with syphilis but not treated even when treatment became available, and the impact that this has had over the years in getting people of color to participate in clinical trials, but also to be trustworthy, to trust the health system. And so when that apology took place, President Clinton tried to point out that this apology was just the beginning, that going forth we have a lot of plans, and NIH, for example, today requires that when people get grants from NIH for clinical trials, the community must be involved in the preparation and planning of those grants, but also in evaluation. I think the only solution to this problem is to develop more community-based strategies for care and research. In other words, we've got to identify leadership in various communities. This institution, Kansas State, has to identify leadership in the communities if you're going to do a clinical trial out there. So the leadership can't just come from the institution, it has to come from the community, and people have to say that we feel that we have a lot of control over what's happening in these clinical trials. And so we can assure the people in the community that these are being carried out appropriately, that you're not being taken advantage of, et cetera. But by the same token, when it comes to patient care, I've been speaking to a lot of church groups. I think churches ought to get involved. You know, if you have older people, for example, in a church, they're not getting their flu vaccine. The churches can either provide the flu vaccines in the church using members and others that are part of them, or they can provide transportation and to assure the people that they're going to, you know, be involved and look after them. Those are the kinds of things that we need more. We need more community-based health services in this country. So, but I also think community-based services are more affordable. I think one of the major problems we have now is that we have a health system that's great, but it's not affordable. The government can't afford it. So many people can't afford it, so we're leaving people out. We need to put more emphasis on health promotion and disease prevention, get people involved, detect diabetes, for example, as early as we can detect it, get people under treatment as early, prevent all those complications that we spend so much money treating. But prevention is not only more cost-effective, prevention is more humane. So we can prevent a lot of unnecessary human suffering, pain and suffering, by focusing more on health promotion and disease prevention. Thank you.
Thank you very much. Thank you. Thank you very much, Dr. Satcher, for an outstanding lecture this morning and for agreeing to answer some very good questions here as well. Our next Landon lecture will be on November 2nd, and it will be David Gergen. So we look forward to seeing you then, and thank you very much for coming. Have a good day.